The COVID-19 pandemic took the world by storm in 2020, forcing many state leaders to take the decision to close up the economy. This has had a significant global impact in all levels of society, affecting our personal and professional lives. As an occupational therapist, we play an integral role in ensuring that our clients achieve their maximum level of functional independence in their work, leisure, play, school, personal management, and sleep. We use various methods to achieve this, such as specific rehabilitation techniques, compensatory techniques, equipment, structural adaptations, and many more. Due to the nature of our interaction with our clients, our patients, their caregivers, and other supporting professionals, we've had to quickly adapt the way we're carrying out our assessment and intervention strategies. Good day. Welcome to Conversations with Us, a space where we will discuss and explore occupational therapy-related topics with other occupational therapists and other professionals, more specifically, healthcare professionals. My name is Mapule Masamola Ralihika, an occupational therapist by background, qualified in South Africa, and have been practicing both in the public and private sector in the United Kingdom for over 15 years. In our first conversations, we will be exploring various changes happening within the occupational therapy practice as a result of this pandemic. We will be interviewing various guests about their journey before and during this pandemic. Please stay tuned. Our first guest today for Conversations with Us is Mrs. Sital Shah-Hopkins. Hi, Sital.
Hey, Mapule, how you doing?
I'm fine, thank you. Thank you for joining us today.
Of course, thank you so much for asking me to be part of your podcast.
Fantastic. So Sital is an advanced occupational therapist. She works predominantly with acute stroke and within stroke rehabilitation. But as we all know, occupational therapists work in different areas if need be. And Sital has been working as an occupational therapist even during the pandemic. First thing before we start with the podcast, how are you feeling?
Better. It's been quite a challenging couple of months, which we'll get into in a minute. Mm-hmm. But I'm glad to say, both from a personal perspective and a professional perspective, it's slowly getting back to a bit of normality, which is nice. So yeah.
So before the pandemic, you were working in stroke or stroke rehab?
Yeah, so predominantly it would be on a stroke rehab unit of 25 patients, mm-hmm. In conjunction with a couple of other OTs, OT techs, another therapist. Mm-hmm.
This was in an acute hospital setting.
Yeah, so it's an acute, busy hospital setting. Mm-hmm. I'm one of the seniors across both units, the acute and the rehab side. But I'll predominantly usually be on the stroke rehab side, sometimes having to help across sites if need be. The work usually would be assessing stroke patients, working with their goals, and delivering OT to a stroke population.
Yeah, great. And it sounds very, very busy as usual. And has there been any changes, like between pre-COVID and post and during the COVID session? Actually, it's not post-COVID yet, but yeah, has there been any changes, let's say, to your practice or the way you manage patients or anything of that sort?
So I guess what I can start off with just briefly explaining what happened during the COVID period. So it was started I guess sort of mid to late March. Mm-hmm. So like I said, usually it would be working with X amount of other disciplines on a very busy stroke rehab ward. Mm-hmm. And what happened pretty much I guess towards the end of March, is the stroke rehab ward became a COVID ward. So a lot of our stroke patients went onto the acute side. So you had a mix of acute and rehab patients being managed on one ward. And then the ward that I was on was pure COVID ward. It was, every day was different. You didn't really know what you were dealing with from day to day. So with patients who've had COVID, everyone's different. Doesn't matter about your age or anything. Everyone's body manages it differently. Yeah, in a very different way. And I guess I can kind of split the patients we were managing in a couple of probably about 3 or 4 categories. So the first category would be with patients who were just not well. So it would be around working with the other members of the team and the nursing team to deliver nursing care. These patients weren't oxygen, they weren't even able to feed themselves or sit out for too long a periods. So it'd be working very closely with the nurses, trying to think about alternative way of doing things, maybe sitting out in a supportive seating,
but still sharing, functional, even though they can't do anything or they're not well enough to do anything.
So these patients weren't well. They were very, they weren't oxygen. It was just about helping them have some kind of quality of life. So feeding them, giving them bed washes, helping the nurses with changing pads. So it was less OT, more kind of just helping them with the basic daily tasks, really. I guess the second category would be with patients who are a little bit more stable. They were still on oxygen, some of them. And this is where it got quite tricky, because you're used to dealing with your stroke population, your stroke rehab. COVID is very new. It affects the body, well, it affects everyone in different ways, and we're still trying to establish how it affects everyone. So yeah, those who are a bit more medically stable, we would do our normal initial interviews, find out what's important to them. It might start off with maybe getting them to do some transfers in and out of bed into a supportive seating, a lot of activity analysis. So, breaking things down to short periods,
what sort of sections do you get with those patients? Is it more fatigue? Is it muscle weakness? Or is it just in that second category? What sort of symptoms do you generally get? So
with these patients, fatigue is one of the big things. So they can't sit out for long periods. If you are going to get them doing anything from bed mobility to even washing their face, you've got to really keep a close eye on the saturations, because anything can affect that. So it was about working really closely with other members of the team, your physios, other members of the team, to closely monitor what we do and their saturations. So yeah, fatigue, teaching them lots of energy conservation, pacing, problem solving, showing them kind of compensatory strategies. The other thing, what I found with a lot of patients, which is making a bit more sense now, and it's coming out more and more when you're dealing with these patients, is the cognitive aspect. Yes, you get muscle wasting, you get so fatigued, but also you're going to get the cognitive element of it as well.
So what's that cognitive elements? Is it
fatigue?
What about things like memory and the level of concentration, perception, or that's not impacted at all? Or is the cognition around the fatigue?
Yeah. So these patients who haven't been to ITU, they've had COVID, they've come straight to this ward to help them, work with what's going on. It's mainly around the concentration. So again, it's everything you do, from giving them advice, from problem solving and doing things with them. It's about acknowledging that not everything's going to go through them. So a lot of practice, breaking things in small chunks. And the third category is for those patients who are medically stable and for many different reasons, unfortunately, are not really going to benefit from rehab. And it's about getting them home as soon as possible. So I guess those would be the three main categories, and you just haven't got a clue what you're going to deal with as you went onto the COVID ward every day.
Then when you're getting them home, I just want you mean the discharge planning aspect of it. Can you just quickly talk us through the discharge planning? What kind of things would you be looking at from an OT's perspective?
Yeah, sure. So again, what we found is as COVID happened, a lot of pathways were being introduced by a lot of the management. So it was about adapting very quick. So you would sometimes have those patients that don't need to be on acute ward, they're medically stable, but they are benefiting from rehab. So you would link in with the discharge team about getting them to the rehab wards for COVID patients.
Okay.
And then you would have the other extreme where, unfortunately, as soon as they become medically stable, we were dealing with a very pressured environment where once they're stable, it's about getting them home as soon as possible. It's about being in an acute setting, but especially around the COVID time. Some patients would go down the rehab pathway. Those patients, for whatever reason, who weren't benefiting from rehab, and for those who just wanted to go home as soon as possible, the discharge planning would be identifying what their care needs are. So I don't do that alone. I do that with everyone, every member of the team, from the nursing to the speech and language, the dietetics, to the physios, to the doctors, everyone.
Pardon,
my lovely.
And the tissue viabilities as well, all involved. Yes. The whole team.
Definitely. It's a big MDT thing. As an OT, it's about identifying their care needs. So you might do some assessments, you might liaise with the nursing team about how regular they need to roll, how much help they need from a nutritional perspective, how quickly they fatigue. So instead of, they physically might manage a strip wash, but because they fatigue so much, you might want to look at bed wash. It's about the equipment side of things. So we had a lot of patients who didn't need the rehab side of things go home as a new hoist. And and usually when you're planning a hoist discharge, you normally do a lot of face-to-face case conferences, let's say, on the ward with the family.
Okay.
You might do joints with the family.
No access visits.
No, and that's been it's been a
big change in practice.
Yeah. So typically with a hoist discharge, a new hoist discharge, you work with social services, all the team members, but very importantly the family members and the patient, because it takes time to come to terms that you're going to go home being dependent on two carers for everything, and ultimately a hoist for your transfers. Obviously we didn't have that. Family members couldn't come. At that point we were doing lots of conversations with the family, and they appreciated that. It was a way for them to know how their loved one was doing, and ultimately they just want their relative home as safe as possible. But the conversations took longer because family members, patients, they're grieving. It's shock.
It's a big change.
Big change. And that was hard. That was really hard. I'm a rehab therapist.
I know. So it's quite difficult to convince you to go straight to discharge planning.
You normally have that kind of episode to give them a chance. The reality is you had to make those decisions. You didn't make those decisions alone. You work as a team. The key things as an OT would have been talking to the family, talking to the patient where appropriate, getting photos from the family. So not doing visits like you normally would, and working with the equipment stores. We were adapting very quickly to how COVID changed our practice, and so was equipment stores. You know, making sure that when they're doing certain deliveries and stuff, they are working, basically managing the whole health and safety aspect. So yeah, it would be about identifying equipment, linking with social services, doing reports, speaking to family members quite a bit, and just reassuring them that we are going to get their loved one home as soon as everything's in place. So yeah, those would be the key things. And I guess as an OT, you kind of get used to that aspect, hoist discharges and talking to family members. I guess the key difference was the time frame to make those decisions. And normally you would do more face-to-face discussions with your next of kins, and ultimately do a visit to the home. So
and then what about technology? Did you guys use technology by any chance, or
so back then, I say back then like it was years ago. So in March and April. But back then it was ultimately using a lot of technology that we had then. So emails, photos, and it worked fine. You fast forward 5 months, 6 months down the line, and I haven't actually used it yet, but we do have this virtual technology about access visits. And I think that was one of the positivities, in the sense that yes, it was challenging. Yes, you had to think on your feet, be very flexible, adapt very quickly. But one of the things, you know, if we're trying to work in an acute setting and do so much, you know, juggle everything, and just trying to minimize the time we spend to still do a good, effective discharge plan, it shows that access visits are not needed. There are other ways.
There are other ways, definitely. Moving on with technology and needing to adapt. Do you think that's the way for the future, where everything is going OT-wise in the future?
I think so. I think, obviously, I don't want to completely eliminate the human touch. I think visits, there'll be like a case by case, but even though things are getting a little bit more normal at the moment, we're not over this. And I think we just need to be very conscious that everything we're doing for our patients, it's in their best interest. It's working with them and their family members, but also just trying to work with the with what we know about COVID, and being protective both for us and for them. And technology is a big part of that. You know, not having to put yourselves or other people at risk, but still getting the same job done ultimately.
Oh, wow. And then would you say your relationship with community therapists, you're using community therapists more now than you did before the COVID, or do you think it's about the same?
I would say now we're using them a bit more. So as we're adapting, the community services we're adapting. So where I work, it's a big hospital in London. We're working with different boroughs, and each borough had different rules. Some community therapists stopped, some got deployed to do other things, because what we were dealing with lots of unwell patients who unfortunately just wouldn't tolerate with community rehab. As the months have got along and things are getting a bit more normal, services are becoming a bit more normal as well. So I would say now we're doing more referrals for our stroke patients. Things are opening up and getting back to what we used to do.
Like you used to love as well. Used to love doing
Yeah.
as well, yeah. So
What
now,
was quite what was quite normal to us
yeah.
before March.
Wow. And since then, have you been seeing, or of late, have you been seeing any stroke cases of late, or?
So yeah, I would say probably around June-ish time. So normally what would happen is so we've got the stroke rehab ward and then the hypoacute side of things, and every day, so the hypoacute ward, you would normally get quite a big turnover. That's a normal pathway with the strokes. And on the rehab, again, you get quite a quick turnover. During the COVID period, around March and April and parts of May, we weren't really seeing that. Now it's getting a bit more normal, where it's predominantly more stroke patients. It's getting much more busier. It's working with what we're used to on a hyper ward and stroke rehab. Yeah.
Oh, wow. Oh, that's so good. I'm glad things are going back to normal. Hopefully in the future, I'll be able to invite you back so we can talk about more stroke pathways, not just for the UK as well, because that could help other countries to see how different therapists or occupational therapists, practice with regard to the stroke therapy rehab. So I'm looking forward to that. Okay, everyone, thanks Sital Shah for the conversation. This was very, very informative. Hopefully other people will learn a thing or two about that. From that, look, God, my English is running away. Maybe we'll learn a thing or two from that, and we look forward to hearing all about it. And hopefully in a few months' time, this whole COVID thing would have just disappeared, and we'll all be going back to normal.
Definitely. I mean, one thing I would say, for those who are, everyone's in a different period of their COVID experience, but one thing that kind of helped me, and I'm still actively reflecting, is it's okay not to be okay.
Yeah.
And it's okay to, speak to the people that you work with, and obviously speak to people in your personal life as well. And just take a bit of a a pause, and say, actually, I'm having a moment. I just need to go have my moment and then come back. And I've been very lucky that the people I've worked with have been very supportive. You
guys have been very, very brave, very brave. It's very brave to be working in an acute setting as it is, but just under such circumstances, it's just something else. So I hope after this that everyone really appreciate the role that you played and the role that you continue to play. Thank you.
Thank you so much, Matolweni, for having me.
Oh, thank you. Next, our participant is Rethabile Matolweni, an occupational therapist, independent occupational therapist who has worked in both public and private sector in South Africa. Welcome, Rethabile, to Conversations with us, and thanks for joining.
Thank you so much, Mapula. It's such a privilege to be part of your show. Thank you.
You're welcome. So, Rethabile, tell us more about your current practice, or maybe should we start a step back, your practice prior to the COVID pandemic?
Okay, I'm in a very interesting space as an occupational therapist. I'm in what you call back at home in South Africa as the health risk management space.
Oh, wow.
So, health risk management space, and I'm working for one of the biggest, do you want to call it insurance companies or health risk management companies, right? And a bulk of our clients is public sector clients. So what we basically are doing would be assessment of disability and incapacity, medical incapacity for public sector employees. So if, for instance, a member from the South African Police Service wants to be retired on the ground of ill health, it comes to our division, and we will do what you call a desktop assessment, find out if you've got all the collateral information, do the assessment, and the outcome of that assessment, obviously there will be a need for us to refer an occupational therapist on the ground or for us to intervene ourselves. to do the functional capacity evaluation, because you can't just rely only on other medical reports. So if, for instance, one was in a motor vehicle accident, yes, you will get an orthopedic surgeon's report, but you require an occupational therapist to tell you the extent of the occupational dysfunction, if I can put it that way.
Like the functional restrictions in layman's terms.
Yes, exactly. And also advise the employer if the person is going to be able to go back. So the outcome of such an assessment would either be, yes, employee A is able to perform all their functional duties, or employee B is still unable to employ their functional duties. However, if you get them a specialized chair, if you give them a footrest, if you make modifications in their bathroom, if you do ABCD, they may be able to go back. Or employee A can't do functions that are prescribed, but can be able to do alternative functions, but ensure that then the environment is like this. We go and conduct what we call work sites visit, and worst case scenarios, which is a place that none of us want to go to, is when then you say, unfortunately, looking at the extent of the injury sustained and the current functional capacity, it is not in the interest, or it is not advisable for the employee to go back to work, and they then could be retired on the grounds of ill health. And this happens across the entire spectrum. It could be physical injuries, it could be prolonged medical conditions, it could be mental conditions, cognitive conditions. So then we're able then to advise. So we're sitting in an advisory.
So more consultation and advisory.
More consultations, and sometimes then we would then have to contract occupational therapists who are in private practice, because then we can't be a player and a referee, because there's financial implications on us based on the outcome of the case. So then by law, we are then expected to contract occupational therapists on the ground to go then conduct these assessments, and then we take outcomes of these assessments, and then we communicate them to the employer.
Okay.
So that is one aspect of my
what you are doing. A woman of many hats.
Yes, but still within the OT context, right? I think for me, I have taken. I think we've had a conversation about how OT within the South African context is very rehab based, right? For me, my approach was, whatever is happening in the hospital, well and good by our colleagues, but at the end of the day, there must be sustainable integration of persons back to their roles. So as much as I'm not within the clinical environment, I'm just making sure that then if you're employed, you go back to employment, and the environment is conducive for you to be able to carry out your role as an employee.
So I'm a holistic view of an individual, rather than just looking at the physical or the mental health or the cognitive on its own. So it's looking at the whole picture of the individual. Yeah.
Yes. And also another aspect then, which at work we don't normally outsource to independent occupational therapists, you find that then one runs with such, I run with it myself, is the issue of then the training and the awareness. So the moment an employer is sent a report that says that unfortunately Mapule, yes, she's got diabetes and she's got secondary issues like visual impairments and so forth, then one needs to go and do some education to say, how do you accommodate, what is visual impairment, and how do you accommodate, what are the do's and don'ts, what are the support, what are the assistive devices, and if they are worn out, what do you do? And also of very importance is making sure that then the disability policy of employers, right, aligns with the national regulation, and they are understood. So there's a lot of policy training that one does. So this is my space, and I'm sure it's very different.
Yeah,
That's
it's
my
a beautiful
I love it.
space to be in. It's a beautiful space to be in because I know when it comes to policies for disability policies, most people will only consider things like disabled parking, using a lift. They'll only look at the physical. They ignore all the other aspects of
Yes.
the disabled or the restriction or limitation that a person can
Yes.
have. So that's a beautiful area for you to be in, and it's a really appreciated area. So have you been working throughout the lockdown? Because I know South Africa has had the lockdown since March this year.
Okay, it's been tricky because the bulk of our clientele are people that are employed, right? So if we can go back to our varsity days, if I can put it loosely, so from the different occupational performance areas, I'm much more interested in work. And because the country has been on lockdown, a lot of them, the bulk of our clients are actually working from home. And basically what the lockdown is all about is, let's just make sure that then people survive. So all of these other, yes. So one of the government departments, which is the custodian of managing incapacity and disability within the public sector, actually came back to my organization to say, can you please assist us in ensuring that the policy that drives the assessment of incapacity and disability is still implemented during lockdown, and how do we then make sure that then we adapt to lockdown conditions? And we did respond with a proposal to say that, number one, lockdown itself, COVID itself, is going to create a lot of issues in terms of the performance of employees. You've got prolonged absences, and remember, the moment and employees that then become sick are employees with pre-existing conditions. So obviously the ability to perform your duties is going to be much affected. So we need to then be on the lookout to say that those employees which were incapacitated and not necessarily having sustained disabilities, we make a follow-up, because now COVID is going to come into the mix and complicate a lot of things.
Everything that you've
complicates a lot of things. And obviously when people come back, the issue of, are they ready to presume their occupational duties, right? That's another story altogether, because we don't know the animal we're dealing with, which is COVID. Right? One day it's a respiratory condition, the other day there's cognitive, because there's neurological fallouts. And are we convinced that? So one of my colleagues spoke about, we must be very careful in using the term COVID recoveries. Because
it's a big spectrum. It's a big spectrum of recoveries from everyone I've spoken to. It's just,
so it's crazy. So where we are now in my space, we're trying to develop sort of a working document to say that people may have recovered or people may have survived death, right? But functional recovery, where now they're able to go back to work, it would be risky for us to take someone from ICU straight into the firing line in the police force. So that's when then you would need your occupational therapist to conduct a functional capacity evaluation. And if there's any fallout or gap, per OT's recommendations to say this person may actually need physio because the muscles were wasted, hence they're unable to stand for the entire day, then we then call in our physio partners. A lung takes time to heal. COVID is a respiratory condition, amongst other things. So issues of fatigue and lack of physiological endurance may make people not to be able to work a full 8-hour day. Then an occupational therapist needs to come in and say, this is the gradual return to work plan that we recommend. So my space is around the area of work. So COVID for me is actually presenting an opportunity, an exciting opportunity for occupational
therapy.
Sounds
very exciting,
to draft and implement tangible return to work plans for employees who have actually, in inverted commas, recovered from
Recovered,
COVID.
yeah. Survived death, in other words.
Survived death, yes, because we don't know this.
You don't know what recovery is. That's how
Yes.
at the moment they are defining recovery, surviving death.
Exactly, it's exactly that, surviving death.
Yeah. So going forward, your thoughts, do you think the role of OT, let's say in your space or the space that you're covering at the moment, do you see a change, a long-term change in it? Or do you see yourself reverting back to how you were practicing before? Or is it the combination of the two?
I mean, COVID has made us reflect on a lot of things, right? On the way we do things and on the how part.
Mm-hmm.
So going back to the normal was not normal, right? We have to create, COVID is creating a new normal because it caught us all off guard, right? So for me, I think because I'm working within a government space, you don't change policy overnight. So I can't go back to my clients and say a total overhaul of policy, because it takes time, it takes years. There's also issues of politics or who is in government at that time. But from our back end, as now the health risk managers, right? A little bit of proactivity would now be required. So we don't sit as occupational therapists and wait for a person to go on an incapacity until they sustain a disability. They should be signs. So a sort of a risk-based approach is now needed to be taken, that because we do get medical records. So when you're perusing these medical records and the person has already sustained a stroke, you see that when you're getting all these signals, there was a headache, there was another headache this month, another one, another one. So a role of case management, if I can put it that way, OTs need to be prominent in that role, because can we not treat incapacity or disability? Can we prevent it from happening? So I think that approach then becomes very, very important. I mean, already, if I am 20 without any history of hypertension and I'm in the police force and I'm reporting these headaches, because I know as an occupational therapist that what could go wrong if there could be a neurological fallout. So an approach wherein we say, let's come in, and if it's and before there's a disability, and if it's a mental or behavioral or cognitive issue, you would want to also be proactive in saying that the stress that is already is forever reported, how then do we avert it? How is the working environment? I mean, I always say it's very easy to reasonably accommodate for a physical condition, but it's another ball game for mental and psychosocial issues. Do we come in and reasonably accommodate much earlier before we then totally lose a function? And that's that. For me, my view is this: post-COVID, we may not be able to change some of government policies, but as health risk managers, we need to take a position of being so risk-based rather than reactive, getting cases of people who are already incapacitated, because our clinical practice make us be able, all of us, to see that, yes, there is no disability here, but if things go in this trajectory, you may then have losing total loss of function. So for me, I think we need to just be very much proactive in our approach rather than being reactive and manage disability when it has already occurred.
Okay, very interesting, very informative. Yeah. And then now, are you guys doing a lot of face-to-face assessment, or is it you do a lot of using technology a lot now?
Exactly. When we're in lockdown level 5 and lockdown level 4, we were not doing any face-to-face interactions. And perhaps maybe your colleagues have raised this, because the nature of our assessment, when you're doing a functional capacity-based assessment, we are of the view that observation is critical. Perhaps our technologies are not that advanced, because also I put myself in the shoes of an occupational therapist that would need to conduct these FCEs, and I realized that legal room, I mean, it can only be an interview, and an interview is one aspect. So we don't have online functional activities.
No.
No, we don't. I'm not sure in your other side of the world. So we had to stop with the functional capacity evaluations until now we're at lockdown level 3, and obviously there had to be an undertaking from the occupational therapists that we're sending patients to or clients to for the minimum adherence to the safety measures. And perhaps this is a discussion for another day to say that our assessment tools, is there a need then to move with the times and conduct this assessment electronically? Because we were not, I was not referring anyone to face-to-face functional capacity assessment during levels 5 and 4.
So there's definitely a possibility of a scope right there. So our scope is constantly evolving, constantly changing. So hey, you never know, 2-3 years time, that might be something. Yeah. Okay, so anything else you want to add? I think this is the end of the assessment of the interview, or shall we say just a conversation. Yeah.
Thank you so much for this opportunity, and I wish and I hope that whatever that I may have presented, which is within my work context, has actually enhanced your bigger interviews with my other colleagues, and of course, for me, perhaps one day when time allows, then we can sit as a panel from the different working environments and then just share insights and share insights and ideas, because I think what has actually compromised our profession is that there's legal collaborations amongst clinicians, so we're forever working in our small corners. So thank you very much. I'd really appreciate an opportunity to be sharing our insights from the South African perspective.
Thank you so much, Rethabile. I really appreciate it. Everyone, look out for this lady, Rethabile Matolweni, for us. Thank you, Rethabile.
Thank you so much, Mapule. Thank you.
This is the end of the first segment of our first episode. Thank you for watching. Please like, share, and press the red subscribe button for future episodes. My name is Mapule Masamola Ralihika, and this is Conversations with Us, a space where we will discuss and explore occupational therapy related topics. Thank you.